All right, so this is the 2020 protocol assessment, also known as the Mike and Paul show. So we're gonna go through the answers to the protocol assessment and hopefully give you a better understanding of why we chose the answers we did. So first, a few opening comments. This, like last year, is an open book review of the protocol. We encourage group participation. I think that's a better way to learn. This is a pass-fail, but there is no passing grade. To pass, though, you have to take the assessment either by yourself or with others, and you have to watch this whole video. So hopefully we'll keep it to about an hour. Any comments there, Mike?
I think it sounds pretty good. We'll talk fast.
We'll talk fast. I do that well. So the first question had to do with working a patient in VF arrest. You shock the patient, and after a minute of CPR post-shock, capnography went from 10 to 50. So what does this most likely suggest? Did you displace the tube during your compressions? You're providing better quality CPR? Has there been a return of spontaneous circulation or ROSC, or is it time to quit? So I chose C as my answer, that there is a return of spontaneous circulation. Actually, if you look at the protocol for high performance or high quality CPR, we have now added capnography as an alternate or a surrogate for pulse checks, so that my preference would be, if you shock the patient, just keep compressing and watch to see if the capnography changes.
So you're perfusing your lungs a little better and getting your CO2 out?
Yes, that is a good way of looking for ROSC. So I would look at that as a better way than doing a pulse check every 2 to 4 minutes.
Perfect.
Second question is, you have a 25-year-old male who's a driver of an auto involved in a freeway accident. He could not get out of the vehicle, and he has an obvious femur fracture. The patient has no spinal tenderness, is not intoxicated, and has no obvious neurological impairment. Based on our protocol on spinal motion restriction, do you need to place this patient in a collar? My answer is yes, because while the patient has no spinal tenderness, he's not intoxicated, he has no obvious neurological impairment, he has a distracting injury, which is that left femur fracture. And if you look at our protocol, the algorithm that goes with it, that box at the bottom of the algorithm talks about what's an unreliable patient. Unreliable patients require collars, and this patient would be considered unreliable because of this distracting injury. He's having so much pain in his femur and his leg that he could have a neck injury and not be self-aware.
Can I just give him a bunch of morphine and the pain will be gone?
Yeah, but then it's another reason now he's intoxicated and incompetent.
Yes.
So that's also a time when you wouldn't let him sign the refusal form after you hit him with a bunch of morphine.
Good thinking.
All right. Question number 3. In our protocol, calcium chloride is indicated for the treatment of dialysis patients in arrest, bradycardia due to calcium channel block or overdose, hypoglycemia or eclampsia. Drum roll. The answer for me is 1 and 2. We routinely use it for patients in cardiac arrest who are on dialysis because calcium is the antidote for hyperkalemia, so we assume that their cardiac arrest is in some way related to hyperkalemia. We occasionally see patients in channel blocker overdose, and those patients can really go to hell in a handbasket fast. I've had a couple patients where I'm using 3 or 4 drugs, including IV calcium, to try to get their pressure and their pulse rate up. So bradycardia due to calcium channel blocker overdose is also an indication for calcium chloride. Hypoglycemia we treat with dextrose, and eclampsia we treat with benzos and magnesium sulfate. Now we've got a pediatric case.
All right, let's see. Here you have a 20-month-old little girl. She grabbed some ramen noodles and pulled it on top of herself. She has partial thickness burns to her trunk, her left thigh, and most of her foot. Her face was spared, fortunately. What would your appropriate option be? And obviously this thing's going to hurt, so we have a choice of just pain control and follow up with your doctor versus just grab her and take her to your nearest hospital. My choice would be C. Give her some pain control. Nasal fentanyl is probably the best that we have in our protocol. Cover it up and then get her to a burn center. In this case, in Columbus, it would be Nationwide Children's.
Okay, and we do not use...
We don't put a lot of goo on it. The
goo.
D is antibiotic cream, ointment, butter, Crisco, nothing. Just put a dry dressing on it and bring her in.
And we don't use wet dressings.
We don't use wet dressings anymore. It's I like wet dressings. No, I don't actually.
Because hypothermia, that's why I don't use it.
That is true.
That was my presumption.
The new burn stuff is You don't want to get the guy cold. You don't want to keep, you actually, since we're on burns, also fluids. There's our diagram kind of tells you how to calculate the percent body surface area. But since we're talking about burns, our current push for the American Burn Society is less fluids are better. So we don't try to hydrate the heck out of them anymore. Parkland is no more. It's all age based. Big person, 500. Middle-sized person, 6 to 14 is 250 milliliters, and then under is just 125.
Okay. I just took the board exam, and they're still going with the Parkland.
Still going with Parkland?
Yeah.
Okay.
It's not surprising that they're 5 years behind.
I don't think our protocol.
All right, we're going to have a mass casualty question here. You have an auto versus bus accident. On arrival, the incident commander assigns you to patient triage. The first person you come upon is an adult who's not able to walk, has a respiratory rate that's less than 30 respirations per minute, and a capillary refill greater than 2 seconds. We currently use the START triage protocol. So the question is, how would you categorize this patient? A minor, or a patient that can sit and wait, or find a different way to get to the hospital. A delayed, immediate, or expected, with expectant being a patient's anticipated to die. So this is the START algorithm, and if you look at the first question, is the patient able to walk? The question is no, so they're not going to be a minor patient. What is their respiratory rate, or do they have a viable airway? And the answer is yes, they do, because they're breathing. So what is their respiratory rate? Well, the respiratory rate is less than 30. And finally, the last question really is, what is their perfusion like? And this patient has a capillary refill that's greater than 2. So if you follow the arrows through the decision process, the patient's... Next question is auto accident. On arrival, you find this patient. She was rear passenger of the vehicle. She was putting her mascara on when the car suddenly braked, and it looks like the mascara pencil went right into the eye. So the question is, what do you do for this patient? How do you manage this patient? So do you stabilize the mascara pen and cover both eyes with gauze? Do you transport in a supine position? Do you evaluate for other injuries, or do you do everything that we mentioned? So my answer is all of the above. You want to stabilize the pen because it's already done some damage. I can't tell whether this pen is into the eye or in the space between the medial aspect of the eyeball and the nasal bridge or the sinuses in that area. But we definitely don't want to move the pen around. We cover both eyes with gauze, so we cover the right eye so that there's not a lot of eye movement. She's not tracking with her one eye that's going to make the other eyeball move. We are going to transport in a supine position to keep swelling, or to keep her more stable. We're going to evaluate for other injuries because if this was an auto accident. So the answer is really all of the above.
Would you keep her elevated, like at a 30 degree, or?
Currently in our protocol, we got her kind of keep it flat.
Kind of flat, okay.
If you keep her elevated, then there may be some more
leakage?
More leakage, or the object may move more.
Okay.
Now, if there's other reasons to keep the head up, like you suspect the patient's got a significant head injury, then I would go for the brain over the eyeball.
Would you call her a date and tell her she's not showing up when she's putting her makeup on?
I think I'd let her worry about that. All right, question 7. We're having too much fun here. It's the first cold snap in October. You're dispatched on an ill person. On arrival, you find a family of 5, all ill, with a complaint of severe headache, dizziness, nausea, and vomiting. 2 of the children are listless. Which illness should you consider? So should you consider an acute viral illness that's just going through the family? Should you consider carbon monoxide poisoning? Could it be food poisoning, where they had some food that they ate that was all bad and now they're all sick? So which would you consider? Well, I would consider all of them. However, I think I needed an extra comment in that my greatest concern is this family suffering from carbon monoxide poisoning? So the reason I threw in this first cold snap in October is that's when the furnaces turn on. So we start to see more carbon monoxide exposures in October, November, when the furnace turns on, or if the family's got a fireplace with a leaking flue, or if they've got power problems and now they've got a generator that's running in the house instead of outside. So I would always think about carbon monoxide poisoning when you have a group of patients with a constellation of similar symptoms. So this is the kind of the reference card that's in the protocol, and if you look at it, the family's complaining of headache, dizziness, nausea. These are all symptoms that are consistent with a CO level between 20 to 29% in the blood. These patients require treatment. They require oxygen. They may require hyperbarics. That's typically something that's determined at Children's or Ohio State, depending on where they're going to get dived. Do you dive kids?
We don't dive. We ship them over to OSU.
OSU.
Yeah.
My impression is OSU dives a lot less patients than they receive. Often
Probably.
because patients are on 100% oxygen before they arrive, and by the time they get a carbon monoxide level on them at OSU, they're no longer toxic.
Right there. Yeah, this is classic. They always, middle of viral season, they come with viral symptoms, but it's the cold snap, the fall, cool morning is the key, and we do see that every year, it seems like.
And I'm surprised how many of these are diagnosed by the EMS providers, which is,
Really?
I mean, I think that's great.
Yeah.
Okay, this is a medication question. So this is an acute stroke patient that you were called to a freestanding ED to take the patient to the stroke center. The patient has left-sided weakness but is fully awake and verbal. The patient met criteria for IV thrombolytics, which is TPA or alteplase, which is infusing. The patient acutely complains of a severe headache, and his GCS goes from a normal of 15 down to 12. What should you do? Should you intubate the patient? Should you administer aspirin? Should you stop the TPA, or should you just keep transporting the patient and continue your monitoring? Well, the answer for this, the primary answer for this, is stopping the TPA. If you look at our section in the protocol that has to do with additional medications that you may be exposed to or asked to transport patients who are receiving, TPA is one of those medications. And we have an increasing number of freestanding EDs. We have them in Lancaster now. We have them all over Franklin County. So these patients may get TPA at the freestanding. So if they have acute altered LOC or severe headache, then we should stop the TPA, because the presumption is they've converted from a ischemic stroke to a hemorrhagic stroke because of the thrombolytic. We do not administer aspirin on patients who are getting TPA for the first 24 hours. Yes, you should continue to monitor the patient during transport, but that's not your primary activity in terms of this patient. If this patient continues to deteriorate while you're transporting them and their GCS gets down to 9 or even 8 tends to be the intubation point on the GCS, then you would intubate the patient at that point, but not generally with a GCS of 12.
Sounds good.
Okay. I'm going to get some more kids in here.
I know.
You initiate care for an elderly patient who's complaining of severe chest pain and dyspnea. Her O2 sat is 86%. She's diaphoretic with a blood pressure of 154/90 and a pulse of 42. The patient's daughter hands you an Ohio DNR form that is signed by a physician that indicates the patient is a DNR comfort care. Which actions are specifically prohibited by the state of Ohio? IV fentanyl for pain control, transcutaneous pacemaker application, cardiac monitoring, CPAP, or could be BiPAP, but we use CPAP, or are answers B and C prohibited? So if you reviewed the recent MEC-MINIC, we talked about DNRs, you know that transcutaneous pacemaker application and cardiac monitoring are prohibited when a patient is DNR-CC. You can use fentanyl IV or intranasal for pain control, and you can use CPAP or BiPAP to supplement or augment respirations. But transcutaneous pacemaker application or use is prohibited, as is cardiac monitoring. Now, to me, that does not mean you can't use the cardiac monitoring to get the patient's vital signs, or if you think the patient's dead, to confirm that they are asystolic in 2 leads. That's not using it for monitoring purposes. You're using it for diagnostic purpose.
So the monitoring is more, why do I care if I'm not going to do anything about it?
Correct. And I think it's really removing that temptation to notice,
want to do something.
They're in a bad shape. Maybe I better turn the defibrillator on, or maybe I better use the pacer pads or something else. Those are 2 prohibited actions. Now, if there was a patient was DNR comfort care arrest, you could do all of this until the patient went into cardiac arrest.
Okay.
So which means basically loss of pulse or no visible respirations. Okay, 35-year-old suffered a narcotic overdose. For those of you who participated in last year's session, you'll recognize this as a repeat, and there's a couple in here. She's cyanotic, unconscious with a respirator of 6 per minute, pulse of 110. You appropriately treat with intranasal Narcan. What is your endpoint? When do you stop giving naloxone or Narcan? When the patient's fully awake and oriented, when the patient has return of adequate spontaneous respirations, when the patient is in acute withdrawal with vomiting, diaphoresis, and now they're violent, that you want to treat them with Versed or ketamine. Well, the answer is B. We use naloxone or Narcan to get a patient back to normal respirations with normal oxygenation. Our goal is not to use Narcan in the field as a diagnostic procedure. Our goal is not to get them fully awake and oriented, and it's definitely not to put them in an acute withdrawal because we gave them too much Narcan, and then they become violent and a behavioral issue for us. So our goal should be to get their respirations back to a normal state where they are now oxygenating normally.
It's expensive too, so.
Yeah, it's... Okay, a kitty question.
Whoa, kids. All right, so this is a 6-month-old. You're called because the child's just not quite acting right per the parent, not eating so well. The remainder of the history, there's been no illness, no traumas. His perfusion's not great, but not awful. But otherwise, he's alert. He's looking around. He's interactive. You put him on the monitor. You find that he's beating kind of fast, and this is the rhythm strip you get. So first, what is it? It's SVT. And then second, what would you do next? So you got a couple choices here. Intranasal adenosine, that's not a thing. Put an IV in him, give him some rapid adenosine with a rapid saline push, which would definitely be an appropriate action to convert it. C, hit the button. Put a bag of ice on his face. And then lastly, cardiovert him. Well, you have a couple things that actually are valid. So the IV placement, adenosine is definitely in the protocol and an option. Synchronized cardioversion is definitely an option. In this kid, though, he's awake, he's alert, he's looking around, he's interactive. I think you can go down the one path with valsalva movers first in a stable child. At this point, it's the primitive diving reflex of putting a bag of ice over his face. You actually have to kind of get a Ziploc, put the ice in there, put some water in there so it forms to his face and just cover his whole face up. 10, 20 at most seconds, and it should convert him into hopefully normal sinus rhythm. Hopefully.
And I assume you should probably tell the parents what you're going to do before you do it. So
Good point. Yes. So there's a great video from ER. They did this. They had to tell the patient they were doing it, but you're right. Tell the family. Don't freak the family out. When the kid converts and looks better, they'll be happy. But if you do it and they don't know, you'll have an unhappy family.
So in adults, valsalvas don't work real well. What's the success rate in kids?
I don't have a percentage for you, but they actually have pretty good anecdotal relief from them. The new onsets, after doing it a few times, this kid would probably be fine. If you have the ones that have been in it over and over and over again, usually I don't get much results from it.
Okay. And you don't do carotid massage?
We do not do carotid massage. We'll do diving reflex is probably the one thing. Blow through the straw, blow up a glove. It's an option. Does the same thing. Gives you a big, strong valsalva maneuver. I like the ice, though, the best.
Yeah.
It's fun.
Okay. We're going to talk, this is a two-part question. You're dispatched on having a patient having a seizure. It's a 35-year-old female with a grand mal seizure. Finger stick blood sugar is okay at 135, and her husband states that she has a history of seizure disorder and medication noncompliance, which is not a treatment option. Are we going to give the patient intranasal midazolam, intramuscular midazolam, IV lidocaine, or IV midazolam? So, or which one is not we're going to do? So we are not going to use the lidocaine IV. It's not, has no proven effect for seizures. And if you look at our protocol, we have part of the protocol that says for seizures, basically on entry, if the patient's having a seizure, we're going to give them a dose of midazolam, either intranasally or new in 2020 as an intramuscular injection. This is really the same priority that we give for children. Our goal is to stop that seizure. If the patient continues to have seizures or has a seizure with IV access, then we have additional treatments. We can again use the intranasal medication, or we can give 4 milligrams of midazolam IV or IO, or we can give 10 milligrams of midazolam IM. Any of those will work. As I discussed in one of the MEC minutes, intranasal and intramuscular midazolam works faster than IV, simply because if you don't have an IV, you can't give it to them. You got to get the IV started. So we've adjusted our dosing this year, particularly for IV. We're now up to 4 milligrams. And this year, as a 2020 protocol, we can use intramuscular midazolam. And we can repeat the dose if we have to.
How much is too much intranasal medicine?
Well, I tend to go with 10. I've had some patients get 20, but I would like to get an IV and give additional.
Once you get, what is it, a milliliter per nostril, you can't really absorb anymore. Yeah.
And if you wait 5 to 10 minutes to give a second dose, then you can maybe hopefully get more absorption. But I think if you give them one intranasal and they're still seizing and you don't have IV access, I think I would give the second dose IM. Same patient. You've treated the patient with midazolam. You've maxed out the dose, yet the patient continues to seize. So this patient continues to be having a seizure. That I would consider them to be in status. What is your next treatment option? Again, the IV lidocaine, well, I already told you that one's not going to work. IV ketamine, IM ketamine, or intranasal ketamine. Okay, so we're down to 3 different options that involve ketamine. Well, ketamine is okay as an intramuscular drug for sedation. I've not seen anything about using it as an intramuscular drug for seizure disorder. So the answer is intravenous ketamine. And again, if you look at our protocol, we've got the box that says use midazolam, and then there's an arrow. If you used up your midazolam, now it's time for ketamine. And the ketamine's a milligram per kilogram IV push, which is the same dose as what we use for behaviorals. And we have a codicil in that to be prepared to provide ventilatory support. So if you've given this patient, let's say 8 milligrams of IV Versed and they're still having an active seizure, I think the ketamine is going to be effective, but you're going to be at high risk for losing spontaneous respirations. The patient may require airway support with intubation or IGL or BVM. So the kids, it's a very similar approach, just the doses are a little different.
Yeah, the doses are different, and there's a question in here somewhere down the road that we'll get to and go into further detail.
Okay. Question 14 is a 42-year-old male complaining of episodes of palpitations and lightheadedness. He has on the cardiac monitor, and you have IV access, and he passes out in front of you, and you see this rhythm. What do? Do you cardiovert or defibrillate? Do you administer amiodarone? Do you administer mag sulfate? Do you drive faster? Or do you do A and C?
I just changed my underwear.
Yeah. I'll do that after I get the patient back. For me, the answer is A, then C, and I think you have a couple different takes on this. If the patient is awake, alert, talking, and then all of a sudden goes unresponsive, then I would treat him as an unresponsive VTAC. So, torsades is a form of VTAC. So I would cardiovert or defibrillate the patient I would use electricity, and I would treat this patient as a VTAC with or without pulse. If the patient is doing this and they're just saying they don't feel well and they're alert, I might just use the mag sulfate and see if I can abort the episode at that time. If the patient is like this patient and they pass out, I would go to electricity first, but once I got them back, I would give a dose of magnesium sulfate. So I would still give that. Amiodarone I would not use. Amiodarone prolongs QT interval, and torsades is a problem with a prolonged QT. So I would not use amio. I would use mag sulfate. You could use lidocaine, but it's not in our protocol. But for this patient, because they passed out, I would shock and then give mag sulfate.
And drive faster.
And drive faster. I guess I would do 3 of the 4 options. This is a question that's come up, and I keep bringing up questions related to medications and medication errors because for calls that I get from a chief or a battalion chief or a company officer say, hey doc, we got to talk, it usually has to do with a medication error. So I think as long as we're doing these annual assessments, there's always going to be a question related to medication errors, unless something else becomes more prominent. So you're assisting the charge medic with patient care. The charge medic indicates he's going to administer a dose of fentanyl IV for pain control. You notice he opens a vial of ketamine instead of fentanyl. What should you do? And this is a real case. This really happened. We had a patient get a dose of IV ketamine instead of IV fentanyl. It did stop the pain. He got the appropriate dose, but he also stopped breathing and had to be bagged for a moment or two. So there was a lot of splaining to do.
Yeah.
So what are you going to do if you're not the charge medic? Are you going to assist in medication administration? Are you going to take out the BVM just in case the patient stops breathing? Are you going to speak up and point out the medic's mistake? Or are you going to suggest that you and the charge medic follow our protocol and medication cross-check? So for me, the answer is C and D. If you look at the protocol for 2020 and you look at the clinical standard on in-charge medic, controlling protocol and in-charge medic, we added paragraph 3 here, which is highlighted in yellow, which says that patient safety is paramount and that any provider is expected to speak up if they identify an unsafe situation or identify an error that's being made. We've had some providers in the past year or two who've kind of taken the stand that I wasn't in charge, so it's not my fault. From my perspective, if you're aware that there's an error occurring in our culture of safety, then you should speak up and you should point out the error. And then I think we should always look toward using the medication cross-check procedure to assure that the patient's getting the right dose, the right route, and the right medication.
Everybody's responsible for safety, so if you see something, say something.
Yeah, it's a culture of safety. We have to speak up. Here's a patient that we are transferring from the ECF. You were called for altered LOC. The patient's sleepy but has an adequate airway. They've got a moist cough. She's got a large sacral ulcer. Her vital signs show that she's got a fever, her respiratory rate's up, her blood pressure's down, and her pulse rate is up. What further assessment treatment should you do? Should you check capnography? Should you start an IV fluid bolus? Should you request a sepsis alert from the receiving hospital? Should you start an epi-drip if the blood pressure continues to drop? Well, the answer is all of the above. So this patient is septic, and we do have a sepsis protocol. It's been around for 3, 4, 5 years, and it's based on what's come out of COTS and other publications. We have a presumed infection because the patient's got a fever. They've got a cough, so it could be pneumonia. It could be sepsis from the sacral ulcer. She's got a fever, her blood pressure's up, and her respiratory rate is up. So it meets all of our three physical criteria. Blood pressure is not part of the sepsis screening tool, but the patient is also hypotensive. But we also then use capnography as our screening tool or as our lactate surrogate. So if you put the capnography on this patient and her capnography is less than 25, then her serum lactate's probably over 4, which is a key metric for severe sepsis. You think the patient may be septic, so we're going to give the patient a fluid bolus. At least we're going to start it. Our goal is 30 cc's per kilo. You may only get 500 cc's in before you get to the hospital, but let the hospital know because they will include that 500 cc bolus as part of the 30 cc bolus they're going to give the patient. If the patient's blood pressure continues to drop, we have epinephrine drip as our pressor. There's more focus on starting pressor sooner rather than later. So nobody would fault you for starting a pressor if you've also got a fluid bolus started. And then we're going to ask the hospital to have a sepsis alert or initiate a sepsis alert on arrival so that they're all revved up and ready to go for this patient. Another PD question.
All right, you are called to see a 4-month-old because he's just not acting appropriately and sleeping too much. You get the history from mom's boyfriend who says that the dog jumped on him. You look up, you're checking the patient out, and all of a sudden you see he wakes up, but he's still crying inconsolably. You cannot get the crying to stop. You notice some linear marks on the side of his head and his face. Of all the options below, which would you not do? Should you check a blood sugar and put an IV in him? Should you tell the boyfriend who was there he probably should take him to the doctor to have him checked out? Should you put him in C-spine precautions and take him to a trauma center? Or if time allows, would you wait for the police to arrive? Answer, I chose B as being the thing you would not do. This child is non-accidental trauma or child abuse until proven otherwise. So you would not want to give it back to the boyfriend and say, take him somewhere. You want to make sure the scene is safe. If the child looks okay at that point, you can wait for the police. You assume it's a trauma, so you want to make sure his neck is safe and immobilized and taken to the appropriate place. And then the most common thing for sleepy, inappropriate children are blood sugar, so definitely want to make sure that's not the case.
Okay. 18. Which statement regarding helicopters as outlined in our protocol is correct? We have a preferred helicopter service. There are at least 3 services available in our running districts. Do we have one that's preferred? Can we use a helicopter for patient transport if it will reduce transport time? Do we have to have an outright flat prohibition for using helicopters in the protocol? If you use a helicopter, should we document clearly in the EMS report the reasons for choosing the helicopter? So which answer would be correct? For me, the answer is B and D. You may use a helicopter for patient transport if it will significantly reduce transport time. And when you think about transport time, it's not just air time. It's the amount of time it takes to get the patient to the helicopter, to get the patient up in the air, and then what amount of time it will take to get the patient out of the helicopter and into the emergency department. So from my perspective, really our utilization of helicopters should be minimal, and there should be a clear time savings by using the helicopter. And then if you do elect to use the helicopter, it should really be clearly articulated in your narrative why you chose the helicopter to transport the patient. It could truly be that your expected transport time is 45 minutes, in which case the helicopter would be better. Or it could be other indications, but it should be clearly documented in the run report. So we do not have a preferred helicopter service. Honestly, I don't even know how the dispatch centers pick helicopters when one is requested, and there is no strict prohibition in the protocol to use them. I think the general teachings among EMS physicians is that if you can get the patient to the appropriate hospital in 30 minutes or less, you do not need a helicopter. But there are considerations such as distance, traffic, other extenuating circumstances.
Yeah, I just got back from a HIMSS conference talking about helicopter EMS, and it's all over the board. It seems like in Columbus we are so suburban and urban that we don't really need that, whereas other places are so spread out. Montana, they use a lot of air EMS, and London, actually, because it's such a big traffic thing.
Yeah.
But I don't think we really use it that much here, nor do we need to.
I heard somebody speak, London's EMS medical director, and she was talking, and she said they use the helicopters to get care to the patient, not so you get the patient out.
Wow.
They just, to get to the patient, they use the helicopter to get in. It's kind of like Singapore using motorcycle medics.
Yeah.
Just what do you need
get
to
there,
do?
right?
Okay, question 19. You got a thin 24-year-old female developed dyspnea and sharp right chest pain 1 hour prior to calling 911. Breath sounds are absent on the right. Which findings would prompt you to place a large bore catheter into her chest? So, I think the question is this tension pneumothorax?
Right.
So tracheal deviation to the right, tracheal deviation to the left, hypotension, JVD. My answer is B, C, and D. If the patient's got tension, the trachea should go to the opposite side, not to the same side. So if she's got right-sided pain with no breath sounds on the right, you expect the deviation to go to the left. Significant tension is going to result in hypotension and JVD. So that's my quick answer. I did have one of the seasoned medics look at this just for his input, and he asked me when the last time I saw tracheal deviation on a tension pneumothorax, and I had to admit that the last couple I've seen have been on X-ray and not in physical exam. But this is a textbook question. Okay. Which findings suggest that you may have difficult time intubating a patient? A large tongue, previous cervical fusion, inability to see the oropharynx when the patient opens their mouth. That means the tongue is totally in the way. We call that a Malampati 4, or facial trauma. So which of these things suggest you're going to have a tough time? And hopefully would prompt you to come up with a plan for alternate methods of securing the airway in case your initial attempt at intubation doesn't work. So for me, the answer is E, all of the above. And we do have a page or a guidance in the back of the protocol that has to do with moans and lemons, and it covers a lot of these points. So large tongue is just a large physical obstruction. Previous cervical fusion could limit the range of motion of the neck. Malampati 4, again, it's just to suggest that you got a big tongue. And then facial trauma, you just could have blood and gore everywhere, and you may not be able to see your landmarks to place the endotracheal tube. That's pretty much good for kids too.
It's good for kids. Or have no chin.
Have no chin.
Here or band kids.
I always think of the football players that have no neck too.
Yeah.
Especially with pre-paralytic days. You arrive on scene to care for a 66-year-old male with severe dyspnea due to COPD. You determine he needs intubation prior to transport and initiate the protocol for delayed sequence intubation or DSI. Which is the correct sequence of events? I'm not going to read all of the options. I think they're all there. For me, the correct answer is D. We're going to correct hypotension with epinephrine, ketamine IV push. We're going to pre-oxygenate by using the PEEP, the mask with PEEP and the BVM and high flow oxygen via cannula. We're going to give them succinylcholine intravenously, and then we're going to intubate the patient. All right.
You got a 5-year-old child you call because of his shortness of breath. He's otherwise been pretty healthy. Let's see here. He's been vomiting. He's been less active. You show up, he's awake, but he's really slow to respond, but he responds appropriately and complains of some belly pain. He's been having some vomiting. I think I mentioned that. You listen to him. His breath sounds are clear, good air movement, but he's breathing at 40. He's a little tachypnic. His capillary refill is a little sluggish. He's a little tachycardic. What are your best options? Well, he's breathing fast. You give him albuterol. Do you load him in the ambulance and take him to the hospital? Do you check blood sugar and put an IV in him? Or do you place an IV and give him a bolus of half normal saline? For me, we'll pause on the computer working here. I would check a blood sugar. So this child, and put an IV in him. He's presenting like a kid in diabetic ketoacidosis or DKA. He's breathing fast, but he's moving air really well and his lungs are clear. So I would not give him albuterol. I would not just pick him up and move him. You should do something. And then the last one is give him a bolus of fluid. He probably does need a fluid bolus. He probably is a little bit dry, but I would not bolus with half normal saline. So that's the part of that I would bypass. So definitely would need to work him up for DKA, check his blood sugar, and see what you got.
Next one is an ill person. You find a 68-year-old female appears chronically ill, but not acutely ill. Vital signs are okay. Pulse ox and fingerstick blood sugar are okay. The son is present, and he pulls out the POA form and says he wants her taken to the hospital. The patient refuses transport. You've determined that the patient has the capacity to make informed healthcare decisions. What do you do? You can ask the son for a copy of the POA paperwork. You can transport the patient despite her protests. You can not transport the patient and leave her at home, or you can sedate the patient with midazolam and transport. So for me, the answer is not transport the patient. So patients are allowed to make bad healthcare decisions if they have the capacity to understand the risks and benefits. So I kind of set you up on this question by saying that she has the capacity to make an informed healthcare decisions. You can ask the son for a copy of the POA, but remember the POA is only in effect if a physician signs off on it and says the patient's not capable of making their own healthcare decisions. You can transport the patient despite her protest, but you'd better have a good reason for doing so, and it'd be very hard to justify if the patient has the capacity to make an informed decision. Same thing with sedating the patient and transporting. I think that would be considered kidnapping or a battery or something that the lawyers would have fun with if the patient was able to find a lawyer. So I just threw in, we do have the refusal checklist. You can use that to help assess the patient's capacity to make an informed decision. I've had a couple calls on the medical control line regarding this, And we've actually had one patient we sedated and transported, but she was far out in left field, had no ability to understand the risks of refusing for transport. So this patient I'm talking about was sedated, but she didn't have the capacity to make an informed decision. So use the checklist; it'll help protect you.
All right, we have a 10-year-old child with a history of epilepsy, is on Keppra but has missed a few doses. Your call because she is continuing to have a seizure. No history of trauma, a little bit of ill symptoms, and that's all you have. On arrival, she's seizing still. She's been seizing for about 10 minutes now total. What is your next step? Turn her on her side to open her airway, monitor and wait 15 minutes before you do anything. Intubate her to protect her airway using the DSI protocol. Apply pressure to her nail beds, some kind of noxious stimuli to see if she'll come out of it. Or make sure her airway is patent and then check her serum glucose. So for me, I said D, make sure her airway is patent and then check her glucose. We'll go through each one of these things. So history, years ago, used to say 15 minutes before intervening. It's now 5 minutes. So you can give her something to intervene. Intubation, she just needs to stop her seizure. She's not ready to be intubated at this point. If you had a strong concern for a pseudo-seizure, that's an option in C, but I don't think so in this case. She has a history of epilepsy. And then we already talked about D. There's a second part.
And pseudo-seizures no longer called that?
No,
it's non-epileptic. It's politically incorrect to
It's
say
politically incorrect. It's now a
non-epileptic?
psychogenic, non-epileptic event.
Okay. Most will still call them pseudo-seizures.
Yeah.
Okay.
Same child. You check the blood sugar, and the blood sugar is 87, normal, but she's still seizing. What do you do? So you have 3 options here. It's kind of a follow-on to the adult patient we had earlier. Do you give her a weight-based dosing of Versed or midazolam intranasally with the MAD device? Do you put an IV in her and do the same thing with the Versed? Or do you say, oh, she missed her dose of Keppra and give her the Keppra? Well, as Dr. Zeeb said earlier, your fastest route is going to be the nose. If she had an IV in place, I definitely would go that route, but she doesn't. So the quickest thing to do is use the midazolam intranasally to see if you can break that seizure. And again, we can repeat that dosing if we need to.
Okay.
Currently, I guess this is one thing I was going to mention here. If you walk in the same situation and they're seizing and you're on the spot with the midazolam, most of the kids don't really present hypoglycemic. So if you want to treat first and then check a sugar, that's fine. As long as we're doing both those things are probably the necessary, and which comes first, I'm not sure is really as important. Just get them done.
Okay. All right. Trauma question. You have a victim from a farm accident. His lower leg was caught in a combine hopper. Family got him out before you got there. The patient's awake, diaphoretic, confused. I should say at this point there are no other injuries except for the leg. He's got pulsatile bleeding from the leg. His pulse rate's 120, his respiratory rate's 20, and his blood pressure's 80/50. Which sequence of interventions best reflects your treatment priorities? Again, I'm not going to read all of them out to you. I would like to point out that, well, actually, I'll show you which my correct answer is A. So you've got pulsatile bleeding, so we're going to get the tourniquet on there to stop the bleeding. You could also apply direct pressure at that time. We're going to complete the ABCs after hemorrhage control. There's a big increased focus on stopping the bleeding before you worry about ABCs. You know, whichever acronym you want to use. I use XABC, whichever one you want. We're going to give an IV fluid bolus, but we have a target blood pressure of systolic blood pressure of 90 or a palpable radial pulse or 2 liters of fluid, whichever comes first. We're going to give IV TXA. I use saline moistened dressings for wounds like this to keep from drying out the tissue, although there's probably enough bleeding that they're going to saturate the gauze quick enough that you don't need to worry about the saline. And then I'm going to make some attempt to immobilize the fracture. B and C are, to me, incomplete in the wrong sequence. And then D, we do not do field amputations, or at least medics do not. Carol Cunningham is still roiling over an article about amputation in the field in Fairfield County that was published in GEMS. I don't know if it really occurred or not, but there was a suggestion a medic did it, and it is not within the EMS scope of practice. So don't think about amputating in the field. Okay. Somehow I screwed up my graphics on this. That's okay. Which is not one of Ohio's geriatric trauma triage criteria. 2 more proximal long bone fractures, GCS of 14 or less with a known or suspected TBI, systolic blood pressure less than 100, pedestrian struck, or fall from any height, including standing with evidence of TBI. So which of these is not correct? Not one of the geriatric trauma triage criteria. And the correct answer is A, and that's because it's actually one or more proximal long bone fractures for the geriatric population. For the geriatric population, GCS of 14 or less with known or suspected TBI, that's correct. Same thing with a systolic blood pressure of less than 100. For the general population, it's 90. Any geriatric patient who's struck by a car is considered to meet the trauma triage criteria. And then any fall from any height with evidence of TBI is one of the criteria for transfer to a triage or to a trauma facility. So it's this is the same question as I gave last year. I didn't have to change it up at all. Maybe a different graphic. It's one or more proximal long bone fractures qualifies from an MVC.
Sir, when do you become geriatric? For a pediatrician, that's a
70
question.
and up.
Okay.
I'm almost there. Not quite. But.
No.
Okay. This is also a repeat from last year. Patients with asystolic atraumatic cardiac arrest in the produce section of a local grocery. You've been working them for 25 minutes, and the end title is at 5. Can you terminate resuscitation? Well, the answer to this is no. It's not that the patient doesn't qualify based on our standards for termination. It's they're in a public place. So yes, asystolic atraumatic cardiac arrests who have been in arrest for more than 20 minutes with an ETCO2 of 5 that can be terminated in the field, but not in a public place.
I think we decided last year Walmart was okay because no one would notice.
Yeah,
It's Walmart.
yeah. They probably put a price tag on.
Yeah.
70-year-old male, last normal 45 minutes prior to your call. He has right facial droop, his right arm drops rapidly, and he has no right hand grip. Which facility should you transport the patient to? An acute stroke ready hospital, a primary stroke center, or a comprehensive stroke center? And so what do you think? So we use the LAM score to determine where patients go, with the LAMs of 4 or 5, supposed to go to a comprehensive stroke center if the difference in travel time is 15 minutes or less. So this patient has facial weakness, so he gets a point there. His arm falls rapidly, so he gets 2 points, and he has no grip, so he gets 2 more. So his LAM's 5, which is the high as you can be, which means he is a candidate for a comprehensive stroke center if the difference in transport time is 15 minutes or less. And that is based on the recommendations of American Heart Association and the Stroke Society. So this patient is high risk for large vessel occlusion and may benefit from clot extraction, which is why the recommendation is to take the patient to a comprehensive stroke center.
Do we have a time on that? If it started yesterday?
Generally, as we currently have our process, if it's patient's a candidate for thrombolytics if last normal was less than 3 hours, 4.5 hours for a subset of that population. Anybody with more than 4.5 hours since last normal may be a candidate for an intervention if they have something retrievable up to 24 hours out. But if they're more than 24 hours out, the patient can be transported to the closest medical facility. Patient does not need to go to a stroke facility.
Okay.
But I think the key thing is that 15 minutes, it's based on current recommendations. Okay, you have a lady who's 2 weeks postpartum. She's 31. Her blood pressure is 150 over 90. She has a lot of edema. During the transport, she has a grand mal seizure. You already have an IV in place, so what do you do? Just give her some Versed and quit? Do you give her Versed and magnesium sulfate? Or you just put her in left lateral decubitus, give her high flow oxygen, and hope for the best? So the answer for this is B, based on our protocol. If you were to ask an obstetrician, the obstetricians are all about mag sulfate. Most of us, though, know that it takes time to mix up the mag sulfate and diffuse it over 15 minutes. most of us can't just sit there and watch a patient seize, so we're going to give the patient Versed as well. Current protocol is 2 milligrams of IV Versed. For 2020, we did not bump it up to 4, if I remember right, under Eclampsia, but I would probably give this patient 2 to 4 milligrams of IV Versed based on our new seizure protocol, and then give the patient the mag sulfate in addition to that. I think I mentioned last year the number one side effect of IV magnesium sulfate is respiratory depression, so watch the patient's respiratory status as the medication's going in. All right, we have some bonus questions just for fun. Bonus. What is the Tower of Power? Is that a boogie band from the 70s?
Yes.
I think there was a Tower of Power band in the 70s. BVM with PEEP and inline capnography that we use for DSI. Is it a fluid bolus using a large bore IV and elevation of the IV bag where you get that column of IV fluid pressure? Or is it an extrication tool?
It's a ride at some park.
Yeah, it's a ride in some park. Well, the answer is the BVM. This is the same graphic I used during my talk on DSI, and it was basically what the guys down in Williamson County named it. But it has to do with the column that's set up using a BVM, the PEEP valve off to the side, placing inline capnography, putting the mask on the patient's face with 2 hands to hold the mask in place. And under the mask, we have a nasal cannula that's turned up as far as we can go, giving as much oxygen as fast as possible. So that is considered the Tower of Power.
I like it.
And it was
a boogie band.
It was a boogie band. Okay, yeah. I'm dating myself. We're both dating ourselves.
That's right. I've never heard of that.
Finish with a kitty question.
All right, finish up the run here. 2-month-old has increased work of breathing. The child is an X35-week premature baby who's been doing well since he got out of the NICU. Parents state that the whole family's been sick with cold, cough, sneeze, lots of snot, and they're worried because this child is just really working hard to breathe. He's not eating and just sucking in his chest when he's breathing. You look at him, he's got copious amounts of snot pouring out of his nose, otherwise known as mucus. His lungs, he's got kind of breathing fast, lots of rhonchi, lots of wheezes, global retractions throughout. You want to do something for this patient. What of these 4 would you not do? So this kid is a great example of bronchiolitis. He's got all that snot in his nose. You definitely want to suction that out. Kids are obligate nose breathers, so you want to make sure their airway is clear, and that's one way to do that. He's working kind of hard. He may be hypoxic, but the oxygen's going to actually help him at least feel a little bit more comfortable. Obviously, if he's kind of a chubby kid, you can open his airway a little bit to make him breathe somewhat. The one thing that is not recommended is albuterol. It's not going to do anything for this child except make him more tachycardic and irritable. Bronchiolitis is all about opening the airway by removing the snot and repositioning. We've done everything from antivirals, racemic epi, steroids, you name it, and none of that seems to help. And albuterol out the wazoo, and none of it seems to help. It's just they have to run its course, but make sure they can breathe.
All right. Well, that's it for our review. If you have any questions or comment, please post them on Workplace or send them to me via email. Hopefully this has been as much fun for you as it has been for us. Again, if you have any questions, just let us know.
That's right. We should do this twice a year now.
Might be pushing our luck.
Okay. Sounds good.
So here's the protocol. This is pretty much what I just paraphrased. We're going to prep for the intubation. We're going to pre-treat with epinephrine to bring the pressure up if we have to. And you can use epinephrine after you intubate if they drop their pressure. I don't know about kids, but adults often will drop their pressure after you secure the airway. Their adrenaline rush seems to be gone and they drop their pressure, so we can use epi for that. But once the pressure's corrected, we'll give them ketamine. We'll get the mask on them with the PEEP valve and the BVM and the high flow oxygen via cannula. We'll give them succinylcholine. We'll intubate, and then we'll sedate with fentanyl and midazolam. This year we added an option for a second dose of succinylcholine if needed to continue paralysis of the patient during transport.
I always think of those, once you intubate them, that's increased intrathoracic pressure being positive pressure, kind of kills their preload. But you're right, some of the septic people, the kids, just once you intubate, they're gone.
Yeah, so I I like using pressors, whether it's push dose epi or push dose phenylephrine. I'm always prepared, particularly if a patient looks like crap before I intubate them. Going to be expected, immediate, which is the red tag. If the patient's any much worse than that, they may have to be either an immediate or delayed. But for this patient, we've met the criteria for the patient to be immediate.
Sounds good to me.
And I think there's a version for kids too, isn't there, on START?
There probably is. I don't know.
And I wouldn't be surprised if some of these algorithms go away, because the recent mass casualty events pretty much show that they don't work. That really the gut of the provider is probably that gut response is better or as good as this triage algorithm. Plus, patients tend to often self-present or be brought to the hospitals in a personal vehicle or a police car. So it totally bypasses the triaging process.
Right.